All right, guys, we got another question about disc pain and disc pathologies yesterday. And so I thought this was a really important question to address. I'm going to make like a preliminary video just talking about overarching concepts. Later on, we'll break out the anatomical model and we will do an actual video on the anatomy, what's happening with different approaches, and the whole nine. But to start off, I've seen a few different approaches towards discs and disc pain and disc pathologies. And usually when you go around to different docs within the regenerative medicine community, you'll see each of them kind of address it in a different way. So I'm just going to throw out a couple of the things that I've seen within my clinical experience as far as ways that people address this pain. So obviously with regenerative medicine, you're looking to regenerate the musculoskeletal system, the connective tissues that surround the bones of the body. There's multiple different components of that. One of the first ways I've seen people or one physician really address discs is he places a very strong biotensegrity approach towards the facet capsules. The facet capsules are ligaments which stabilize the entire spine. And so when these become weakened, our facets, which allow us to perform the dynamic movements that we do, extension, forward bending, lateral bending to each side, rotation, they're responsible for so much of the dynamic movement of the spine that they place a very high priority on these facet capsules and they treat them very aggressively. And I've seen him personally have a lot of good results with that. And it's, not as invasive as some of the deeper injections, but, it's just something that he does. So that's one component. Another thing that gets more into the interventional world. So discs oftentimes can herniate, and then they will start to impinge nerve roots and start to cause inflammation in the nerve root itself. So one thing that people do at times is called a transforaminal epidural. And this is where you come in from a posterior lateral approach and you are placing fluid that is going to get into the epidural space and hopefully bathe that nerve root and help soothe that nerve root. There's different solutions that people use for that, but that's one component to disc pathologies that I've seen people use to address, and it's pretty high yield as far as people using it. Other components, other ligaments that stabilize the spine, especially the lumbar spine, are the supraspinous and the interspinous ligaments. These are ligaments that run on the top of the spinous processes, the posterior aspect of the spine, and they stabilize that spine. There's also ligaments that run between each spinous process, and a lot of docs will treat these, and it helps to stabilize the spine and decrease shearing of the vertebrae, help to strengthen it so that it can handle a lot of the stressors that we experience throughout the day. One other high yield approach that you will see, it's not nearly as common because it takes a lot of skill and training, is actual intradiscal injections. This is happening. A lot of people in the country aren't trained to do this, and a lot of people don't do it because of a higher risk profile for infection. But it does happen, especially if the disc itself is a cause of the person's pain. And so this requires very sophisticated imaging, and it takes a very strong attention to detail, but it does happen. And usually it's kind of, like a next step from what I've seen, after you've tried other things. One other component, which is a lower level consideration, but it's always important, is the another component is the muscles that line the posterior and lateral aspect of the spinous process and the vertebrae. One specific muscle is the multifidi. There's been a lot of research that when disc herniations occur, It's very common to have a fatty infiltration of the multifidi muscle, which basically stabilizes that entire spine. Um, and it's really strongly correlated with that. So um, one thing that some physicians do is they address that muscle itself, because if you're addressing that muscle, your strength, it's another way to create stability. Ligaments themselves create stability, but muscles themselves also compensate for ligamentous instability. So people will also address those muscles. Um, Another component is medial branch blocks. A lot of times, facet mediated pain and disc pain can kind of overlap with each other. So, this is one aspect which people address, is addressing either through blocking or treating the medial branches, which is basically the nerves that serve the facet joints themselves. So, it's another comprehensive approach, overarching view of where you can look in and hone in on things that can be addressed to address that whole complex. Because what a lot of people are noticing is that when you address the whole spinal unit and not just one structure, you're usually going to have better results, is what people have seen. So this is just a overarching view. I didn't expect you to understand any of those particular things in a lot of detail, but hopefully get some of the terms out there, get some of the ideas and concepts out there, so that when I revisit this with anatomical videos, for people, it starts to stick a little bit. So I hope that helped, and we'll be back later with more.